Two women walk out of the same hospital with the same breast cancer diagnosis, and they're given completely different treatments. One gets chemotherapy first, the other goes straight to surgery. Why? That's what this video is about. The answer comes down to something most women aren't told at diagnosis. Breast cancer isn't one disease. It's actually several different diseases that happen to start in the same place. Things like whether a tumor is HER2 positive, triple negative, or hormone receptor positive completely change what the most effective treatment plan looks like. And if nobody has explained that to you yet, or if you've been sitting with a diagnosis feeling confused about why treatment looks different from someone else's, this video is going to change that. I'm Dr. Alex Popadich, a breast surgeon and menopause specialist in Wellington, New Zealand. I make complex breast cancer and menopause medicine genuinely understandable so you can make confident decisions about your treatment and your own body. Breast cancer is not one disease. Receptor status explained. Here is the most important thing I want you to take away from this video, and it's something I wish every woman heard on the day of her diagnosis. Breast cancer is not one disease. It's a family of diseases that all happen to start in the breast tissue, but underneath they behave very differently. And the single biggest thing that separates them is something called receptor status. Think of receptors like locks on the outside of the cancer cell. We test for 3 of them: estrogen, progesterone, and HER2 receptor. HER2 is a growth protein receptor. These locks tell us what the cancer is feeding on, and that tells us which treatments will actually work because the treatment has to match the lock. A cancer that's fueled by estrogen responds to hormone blocking therapy. A cancer driven by HER2 can be targeted with very specific drugs that go directly after that receptor. A cancer that has none of these receptors, what we call triple negative breast cancer, needs a completely different approach again. And if you know your receptor status, and you should, you already understand more about your cancer than most women do on the day they're diagnosed. And that's not a small thing. That's the foundation of your entire treatment plan. But the receptor status is only part of the picture. There is a second layer of biology that changes how urgently your team needs to act. And it has nothing to do with what type of cancer it is. It is about how fast it's moving. Tumor grade. How aggressive is it? This is called the tumor grade and describes how abnormal the cancer cells look under a microscope compared to normal breast cells. Grade 1. The cells still look relatively organized, slow growing, less aggressive. Grade 2. Somewhere in between. Grade 3. The cells look very abnormal, fast growing, more aggressive. Grade doesn't change your receptor status, but it can change the urgency of treatment and sometimes the timing of chemotherapy that's recommended. A grade 3 triple negative cancer moves very differently through the body than grade 1 hormone receptor positive cancer, even if both are caught at the same stage. This is why your doctor isn't just looking at one number. He or she is building a picture from several pieces of information together. And when you understand that, the treatment plan stops feeling random and it starts making sense. And now there is one more piece of this puzzle that I want to tell you about. And it's a test that not everyone gets, but for the right patient, it can be one of the most clarifying pieces of information in the entire treatment journey. And most women have never heard of it before their doctor mentions it. Genomic testing, the Oncotype DX score. It's called genomic testing, and the most common version used in breast cancer is called the Oncotype DX score. This test is done after surgery on the tumor tissue that's been removed. So it's not part of the initial diagnosis conversation. It comes into picture once your surgical pathology is back and your team is deciding what comes next. It's not a blood test. It analyzes the activity of specific genes within your actual tumor, and what it tells us is this: for this specific cancer in this specific person, how likely is recurrence? And will chemotherapy actually reduce that risk? But not everyone is a candidate. The test is most useful for a specific group: women with hormone receptor positive cancer, ER positive, PR positive, HER2 negative, with lower grade tumors, grade 1 and 2, at a stage 1 or 2, and either with no lymph node involvement or up to 3 lymph nodes affected. If you fit that profile, this score can genuinely change the conversation. It can tell your doctor whether adding chemotherapy on top of hormone therapy is likely to help you, or whether hormone therapy alone is the right call. And this is exactly why 2 women with the same diagnosis can walk out of the same hospital with completely different treatment plans. For example, one woman has Oncotype score of 14 and the other one has 31. They have exactly the same tumor, let's say 23 millimeters grade 2 with 1 lymph node involved, and they're both 60. But they will have different roadmaps. And for them, this treatment is completely personalized. And it's both correct for both of them. The one who has score 14 will not get chemotherapy, while the one at 31 will have a discussion on chemotherapy, and she can choose whether or not she should have a chemotherapy. But before we go further, if this is already making things clearer, I want you to do one thing. Write down your receptor status, ER, PR, HER2. If you don't know it yet, that's the first question to ask at your next appointment. Everything else in your treatment will build from there. So now you understand the biology, receptor status, grade, and genomic testing. But here is where it gets really practical. Because knowing your cancer type is one thing, but understanding how that actually translates into a specific treatment sequence is another. And this is where a lot of women feel most confused, especially when they hear that some people have chemotherapy before surgery and the others have it after, or not at all. Why some women have chemotherapy before surgery? Chemotherapy given before surgery is called neoadjuvant chemotherapy, and it's not a sign that things are more serious. It's actually a very deliberate, strategic choice. For certain cancer types, particularly HER2 positive and triple negative breast cancer, giving chemotherapy first can shrink the tumor before the surgery. That can mean a smaller operation. It can sometimes mean the difference between mastectomy and a lumpectomy. And in some cases, when we get to surgery and look at tissue, the cancer has responded so well that there is very little or even no remaining cancer cells left. We call that a pathological complete response, and it's really a meaningful result. There is another reason why we sometimes prefer chemotherapy first. It lets us see in real time how your specific cancer responds to treatment. If it responds well, that's valuable information. If it doesn't respond as expected, we can adjust. That's something we can't do if we go straight to surgery. So if you've been told you're having chemotherapy before your operation, That's not a worse path. In many cases, it's the smarter one. But for other women, particularly those with hormone receptor positive, HER2 negative cancer, the sequence looks completely different. And understanding why requires us to talk about what hormone therapy actually does and how the Oncotype score fits into that decision. Hormone receptor positive cancer, surgery first, then what? Hormone receptor positive breast cancer, ER positive, PR positive, HER2 negative, is the most common subtype of breast cancer. And after surgery, the cornerstone of treatment is hormone therapy. Drugs like tamoxifen or aromatase inhibitor that block or reduce estrogen and a progesterone available to fuel the cancer cells. After surgery, these drugs are taken for years, mostly 5, sometimes up to 10 years, and they work. For many women with this subtype, hormone therapy alone is highly effective. But the question your doctor has to answer after surgery is, do you also need chemotherapy on top of hormone therapy? And this is not always a straightforward answer. And this is why in some situations, Oncotype DX score becomes so valuable for eligible patients. If your score comes back low, the evidence tells us that chemotherapy is unlikely to add any meaningful benefit. Hormone therapy alone is the right call, and you can be spared the side effects of chemotherapy that you didn't need. But if your score comes back high, the tumor biology of your cancer is active enough that chemotherapy is likely worth adding because the benefit outweighs the risks or side effects of this treatment. And this is not a guesswork. It's your tumor's own genetic activity helping your doctor guide the decision. And it's one of the most powerful examples of personalized medicine that we have in breast cancer right now. For New Zealand viewers, the Oncotype DX test, or sometimes we use Prosigna, is currently self-funded only in New Zealand, unlike in the UK where it's funded. In Australia, it's not funded as well. But it's also a conversation worth having with your doctor before you assume it's not available to you. So please do ask about the cost of this. Now, I want to address something that comes up a lot in my clinic, because sometimes women go through all of this. They understand their receptor status, they understand their grade, they've had the genomic testing conversation, and they still end up with a different recommendation to someone they know with a very similar diagnosis. And they wonder, why? Why two women with identical biology can still get different recommendations? The answer is that treatment isn't just about the cancer. It's also about the person who has it. Your age matters. Your fertility wishes matter. Your other health conditions matter. Your personal values and what matters most to you about your recovery, all of that matters. A woman in her mid-30s who wishes to preserve her fertility has considerations that are genuinely different from a woman in her 60s who doesn't. The treatment itself might be the same, but the timing, the delivery, and the supportive care around it may look different. A patient with pre-existing heart disease needs a different chemotherapy protocol than a patient with a healthy cardiovascular system. And that's because some drugs carry cardiac risks that have to be weighed carefully. And your values matter too. Some women want the most aggressive option available. They want to feel they've thrown everything at it. The others want to balance effectiveness with quality of life throughout their treatment. Neither of these is wrong, and a good oncology team will ask you about them. because good oncology isn't just about treating a tumor. It's about treating a person who happens to have one. I'll repeat that again. It's about treating a person who happens to have breast cancer. There's one more thing I want to tell you about how these decisions actually get made behind the scenes. Because most women assume their oncologist sits alone in an office, looks at the scan and their screen and decides. But that's not what actually happens. The multidisciplinary team, how your treatment plan is actually made. Every breast cancer patient's case is reviewed by what's called a multidisciplinary team, or MDT. This is a group of specialists who sit around a table, or these days a video call, and review your case together. It's your breast surgeon, your medical oncologist, your radiation oncologist, your pathologist who's done your biopsy, your radiologist, and in some places they might have other specialists like geneticist or plastic surgeon. They look at the images, the pathology, the receptor status, the grade, Oncotype DX, and they arrive at the recommendation together. They debate, they sometimes discuss. They bring different expertise to the same case. And if you're ever unsure whether your case went to an MDT, that is absolutely a question you're entitled to ask. Which brings me to what I want you to walk away from this video with. Because knowing all of this is only useful if you can walk into your next appointment and use it. 3 questions to take to your next appointment. Here are the 3 questions that I want you to have in your pocket when you go to see your specialist. Question 1. What is my full receptor status? ER, PR, and HER2. And what does that mean for the treatments that are most relevant to me? This will anchor the conversation of your specific cancer biology, not a general conversation about any breast cancer. Question 2. Am I a candidate for genomic testing? And if so, how would the result change my treatment recommendation? If your breast cancer is hormone receptor positive and HER2 negative, this question is important. Not every patient needs this, but you deserve to know whether you're one who does. Question 3. Has my case been reviewed by the multidisciplinary team? Not because you doubt your doctor, but because you understand that the best decisions are collaborative ones, and you want to know that process has happened to you. Write these questions down. Take them in. You're not being difficult. You're being informed. And this is exactly what I want for you. So let's go back to those 2 women who walked out of the same hospital with the same 3 words on their pathology report. Same diagnosis, different receptor status, different grade, different genomic scores, different ages, different health histories, different values of their own case. Of course, their treatment plans look different. They should look different because they are different women with different breast cancers who deserve a plan built around them, not one size fits all approach. And that's not the system failing. That's the system working exactly as it should. Now, your treatment plan doesn't exist in isolation. It comes directly out of what your pathology team found when they analyzed your tissue. And I know from the questions I get that the biopsy report itself can feel like it was written in another language. Words like moderately differentiated, Ki-67, lymphovascular invasion. They mean something specific and they matter. If you want to understand exactly what your biopsy report is telling you, term by term, in plain language, I've already made this video for you. It's on the channel right now. Go and watch it before your next appointment. Come in knowing what your report says. Your doctor will notice and you'll be able to have a much better conversation.